Good morning and welcome to the Department of Medicine Grand Rounds. We're excited today to have Dr. Kathryn Woodman, one of our new recruits, presenting to us. Dr. Woodman completed her medical degree in Newfoundland at Memorial University and then completed gastroenterology and GI motility specialty training at McMaster University. Fell in love with Hamilton and McMaster and decided to stay here. So we were very lucky to have her. She's currently an assistant professor in the Department of Medicine and the Division of Gastroenterology. And she has recently been appointed the director of the Clinical GI Motility Lab at Hamilton Health Sciences. And she's also the program director for GI Motility Subspecialty Fellowship. We quite busy academically and clinically. She's has interest. Her interests include quality improvement in GI motility and advancing education in gastrointestinal motility disorders. And to no surprise, she's going to be talking to us about gastroparesis and learning. And I'm actually very eager to learn from Kathryn today as a general internist, seeing many of these gastroparesis cases that are challenging. I'm sure I'm going to gain something to take into my clinical practice today. So without further ado, Dr. Woodman, please go ahead.
Thank you very much for the kind introduction. So this morning we're going to talk about gastroparesis. And the reason I chose this topic is because I think it is commonly seen and it can create somewhat of a management dilemma. So I'd like to start just by acknowledging that we're privileged to provide care in lands that Indigenous people have called their homes for thousands of years. I have no conflicts of interest to declare. And so this morning, what I'd like you to get from this talk is a basic understanding of motor physiology and how that can go wrong to produce a gastric neuromuscular disorder, how we make the diagnosis of gastroparesis, and how we can describe management of general gastroparesis, as well as some refractory cases that can be more difficult to manage. Okay, so I'm going to start with a brief case. So just a simple case. It's a 78-year-old man. He had a 1-year history of nausea and vomiting. His symptoms started after an episode of gastroenteritis that he required a hospital admission for. He presented with early satiety. He had emesis of food consumed the day prior, ongoing weight loss, and he'd never had a gastroscopy, so no previous investigations at the time I saw him for this. So he had quite a lot of comorbidities, as you can see. Important to note that he was type 2 diabetic, which was actually well controlled with no real history of poor control or complications related to diabetes. So we did complete a gastroscopy, no mechanical obstruction to explain his symptom, no significant histologic abnormalities. He did have an incidental duodenal adenoma that was excised, not lumen obliterating, and nothing to contribute to his symptoms. He had a 4-hour gastric emptying study, nuclear medicine, with 30% retained contents. So ultimately, his diagnosis was either post-infectious versus diabetic gastroparesis, but favoring post-infectious given the onset, as well as his well-controlled diabetes history. He was simply managed with dietary changes, a low particulate diet, and he had spontaneous remission of his symptoms. Okay, so we'll go back to medical school for a few slides, and the reason I wanted to include this was to help us understand the pathophysiology of gastroparesis and how we direct our treatments. So the stomach does a few more important things than empty. And when we think about gastroparesis, we think of mostly as an emptying disorder, but there are multiple things that can go wrong in gastroparesis or other neuromuscular disorders of the stomach. So upon eating, the stomach has an important role of accommodation, which is essentially receptive relaxation of the stomach to allow for increased volume. There's also mixing of the stomach, which is a neuromuscular activity to particularly grind solids. And then there's antral peristalsis, and this has to be coordinated with the duodenum to allow chyme to leave the stomach and enter the duodenum at a controlled rate of about 1 to 4 calories per minute. And this is slightly slower in females than males. So this just depicts accommodation and how significant accommodation is. And the reason I want to include this is because we can see when accommodation goes wrong, it can cause significant symptoms. So you see here, the resting volume of the stomach is around 200 mils, but upon taking in a meal, it rapidly increases in volume, and this is mostly due to relaxation. With solids, this occurs mostly in the fundus, but with liquids, it occurs throughout the stomach, like in this photo here. This is resting state versus an accommodated stomach. So the physiology of liquid emptying is quite different than solid emptying. It does not require as much neuromuscular activity as solids do. Mixing is not required, and it is rapid. So when solids are consumed, there is a lag phase before emptying occurs, but with liquids, it's emptied immediately, essentially, and partly this is because of gravity. So this is often well preserved in people who do have neuromuscular disorders of the stomach. In general, higher calorie liquids will be retained for longer, but water moves through the stomach very quickly. So the stomach in the fasting state doesn't just sit quietly, it basically cleans itself out every 3 to 4 hours. The reason I'm including this is because this is something that we augment with certain medications that we use to treat gastroparesis. But ultimately, there are large sweeping contractions that clean out the antrum from anything that's basically been left over from a previous meal. And those are called the migrating motor complexes. So normal gastric emptying, so a normal emptying rate should be a 250 calorie low fat meal should be at least 90% emptied at 4 hours. So you can see here, this is a nuclear medicine gastric emptying study at time 0. This is a radio labeled egg meal. So you can see all of the material is within the stomach. And then there are photos taken throughout the 4-hour period. With the 4-hour image, you can see a lot has left the stomach, and this is a normal study. So I didn't talk much about neurohormonal control of gastric emptying, but I did want to include this point because there is one important hormone that comes up clinically, so that's GLP-1. So GLP-1 is produced by the neuroendocrine cells in the ileum, and this puts a brake on gastric emptying, so it delays gastric emptying as a normal response to slow digestion when there are undigested fats in the ileum. Also reduces appetite. So how do we define gastroparesis? What is gastroparesis? So I will talk about the official diagnosis in a few slides. However, gastroparesis in itself is objectively delayed gastric emptying, no mechanical obstruction, and the cardinal symptoms, nausea, vomiting, and early satiety. There are many different causes. A lot of patients are idiopathic. We do not know what caused their symptoms. We don't know the exact pathophysiology of what is going on. And there is no clear onset or triggering factor that caused their symptoms to start. There is a subset of patients who have a post-viral onset, likely like the case I presented. And these people have a pretty good prognosis over a 1-year period in terms of resolution or improvement of their symptoms. Diabetes, of course, very common cause. More commonly seen in type 1 diabetes than type 2, and usually a longer duration of more severe uncontrolled diabetes. Abnormalities that are seen in diabetic patients include changes in nitrogen neurons, so loss of nitric oxide, which can help the pylorus relax, as well as changes in the interstitial cells of the caul that actually can be somewhat, or thought to be somewhat reversible potentially. Just like anybody with hyperglycemia, someone who has poorly controlled diabetes may also get coinciding physiologic delay in gastric emptying due to an elevated blood glucose. The other important cause of vagal nerve injury post-surgery, so a vagotomy fundoplication vagotomy for medically refractory peptic ulcer disease, it would be rare these days, but whether intentional or unintentional, this is a potential cause of gastroparesis. Connective tissue disorders like scleroderma that we might see, so they have direct damage to the smooth muscle cells. Infiltration can result in gastroparesis. Potentially also, rarely, chronic mesenteric ischemia can result in a maybe reversible cause of gastroparesis. So physiologically or pathophysiologically, what is going on in these patients? It sometimes is difficult to tell in which patient what pathophysiology is occurring. But this is important sometimes to have an idea because it can help us direct management. So antral hypomotility can be seen, and this would probably be expected if you think about gastroparesis. So this would be poor peristalsis in the antrum. And this can be seen with loss of interstitial cells of caul, like we talked about in diabetic patients, decreased neurons, enteric neurons, or a vagotomy. Pylorospasm or increased contractility is important pathophysiology because it can help us direct management if we're aware we think this might be going on. And this is thought to be due to decreased nitric oxide, which can help the pylorus relax. As I mentioned, the stomach has a big role of accommodation with ingestion of food. So it is quite possible that in patients with gastroparesis, they are over-accommodating, so the stomach is ultimately too relaxed, and you lose that pressure gradient to allow the fundus to empty, or the stomach is not accommodating well, and then you get symptoms like early satiety, and this is thought to be related to decreased nitric oxide as well as post-vagotomy. So how do we make a diagnosis? How can we say this patient with this abnormal gastric emptying study has gastroparesis? So there aren't standardized diagnostic criteria like you might see with functional conditions in the Rome criteria. So we would consider a gastroparesis patient to have gastroparesis if they have symptoms that are compatible with gastroparesis. So cardinal symptoms are nausea, vomiting, early satiety, and they can have other symptoms of upper abdominal bloating, pain, but they're usually less prominent, and nausea and vomiting, particularly postprandial, is the predominant complaint. There's no evidence of mechanical obstruction, whether it be on a gastroscopy or an upper GI series. The delayed emptying needs to be diagnosed with a standardized 4-hour nuclear medicine study with greater than 10% of contents retained. So if they had a 2-hour study and it's extrapolated to 4 hours, it's not validated to diagnose gastroparesis. And as well, other testing such as a wireless motility capsule that relies on migrating motor complexes to empty capsule are not as good as a 4-hour nuclear medicine emptying test. So this is the gold standard that should be done for these patients with suspected gastroparesis. This study needs to have been done off of medications that can contribute to that delay. So potentially reversible causes like opiates, GLP-1 inhibitors, and some rare things like cyclosporin or even calcium channel blockers. Anticholinergics might have a weaker effect. So ideally done off these medications. It has generally been identified that food seen on a gastroscopy is not a good predictor of gastroparesis unless it is a diabetic patient who has known neuropathy. So we cannot use this to diagnose gastroparesis. In making the diagnosis, it's not always a clear cut, this patient definitely has it versus doesn't. And there is a lot of overlap with functional dyspepsia. So it's actually thought that they're more likely a continuum rather than a true dichotomy. So functional dyspepsia, these patients present with very similar symptoms, but their predominant complaint tends to be more pronounced postprandial pain or postprandial discomfort, as opposed to a patient with gastroparesis, usually presents with prominent postprandial nausea, vomiting. I'll show you the diagnostic criteria for functional dyspepsia, and you can see how it can become somewhat confusing. But overall, they're likely a continuum, and you can see disorders in gastric emptying and functional dyspepsia, as well as likely part of the underlying neuromuscular pathophysiology of that condition. So the Rome 4 criteria, so you can see that these are quite similar with a lot of overlap. So postprandial fullness and early satiety, and certainly you can have pain and epigastric burning with gastroparesis as well, though it tends to be to a lesser degree or less pronounced or masked by the more significant nausea and early satiety. Okay. So to further this, the symptoms and rate of gastric emptying are not a one-to-one relationship, which is very interesting. So somebody with a very severe delay in their gastric emptying can have very mild symptoms, whereas someone with a very minor delay can have really quite distressing, significant symptoms. And this has been found in a systematic review, a meta-analysis published in 2019. They found no significant association between gastric emptying and upper GI series, though this was limited by somewhat suboptimal methods that were used to diagnose the delay in gastric emptying. So why could this be? Why aren't people having, how come they can have such a significant delay in gastric emptying without having severe abnormalities, and how come they can have just a minor delay and they're having nausea, vomiting, retching continuously? So it's possible that this is a contributor, or the gut-brain axis is contributing to their amplification of symptoms. So we know the pathophysiology occurs, changes in accommodation, hypomotility of the stomach, then there's an increased sensation or increased awareness of their symptoms, and increased awareness of the diagnosis, changes in their eating patterns, aversions to things that have made them sick, amplification with stress, emotional factors, and then a positive feedback cycle in the stomach. So psychological factors that can affect the neuromuscular activities of the stomach, and this goes on and so forth. So this may be one of the underlying reasons that the findings just don't add up to a one-to-one relationship with gastric emptying and symptoms. So we know how these patients typically present. So the cardinal symptoms, other things we often find in these patients are gastroesophageal reflux because the stomach is not emptying. So they may have prominent significant GERD symptoms because of the gastroparesis. Some, if they are more severe in their symptomatology, can have weight loss, loss of appetite in general, and malnutrition. And of course, pain, but usually not prominent. So in terms of managing these people, it kind of separated into three domains. So conservative management should be for everybody, medical treatment, and then interventional treatments for some. So conservative management, so the first thing to consider is, did the symptom onset occur after the start or change in dosage of a medication that's known to delay gastric emptying? So very important ones are the top two, so opiates and GLP-1 agonists, and I'll talk a little bit more about stopping these or what these are doing and if they can be stopped in the next slides. But also consider the other medications that might be contributing to a lesser degree. Are they anticholinergics or multiple anticholinergics, which may have a weaker effect? Are they on new calcium channel blockers, or anything else that you think might have a change in the function of the stomach or smooth muscle? For diabetic patients, an important part of their management, or the cornerstone of their management, is really to maintain optimal glycemic control, because they will get further physiologic delay in gastric emptying with hyperglycemia, as anybody would. So this will be very important for them, and also to prevent further worsening of their gastroparesis. So opiates and gastroparesis. So it's not uncommon that we find patients with a diagnosis of gastroparesis on opiates. And it has been found that patients who are on chronic opiates have higher severity of cardinal symptoms. They are known to delay gastric emptying, and it's thought that they may affect the same pathway in which the interstitial cells of Gall, or the pacemaker cells, are involved, which is involved with nitrogen relaxation of the pyloric sphincter. And there also may be a synergistic effect on loss of ICCs that you see in diabetic gastroparesis, as well as opiates. So there might just be an effect of opiates, but also synergism. This has been proposed. So this is to be considered. It's not always the case that, of course, these can be discontinued, but tapered if possible, or reduced to the lowest possible dose might help their symptoms to some degree. So GLP-1s have become very popular in terms of diabetic management as well as weight loss. And this has created a bit of a dilemma on whether we should use these medications in gastroparesis. So GLP, as we know, is a hormone that physiologically slows gastric emptying. And GLP-1 agonists, when used for medical purposes, also do slow gastric emptying. So the question that comes when you're considering stopping these medications in someone with diabetic gastroparesis is, did their symptoms worsen at the time that the GLP-1 agonist was initiated? Did they get better, or did they get worse at the time that the medication was started? Because we know that it's not a one-to-one relationship between gastric emptying and symptoms. So the question's been raised of whether or not just stopping these is going to reverse any effects that these have caused. So what we do know about stopping these is that weight is gained after they're withdrawn. And there have been case studies that show clear reversibility based on a gold standard gastric emptying study during the medication, as well as after the medication was stopped. So can I say for 100% certainty that this is a reversible effect? I cannot, but it probably is, maybe. So ultimately, stopping these or starting these would require a risk-benefit discussion with the patient. Are the benefits or worsening of their symptoms worth the improved risk of glycemia? And that's a discussion to be held with patients, as well as potentially worsening, and a plan to stop these if symptoms do worsen. So nutrition is the cornerstone of management for all patients. It's the first and the last thing to do in management. So the goal for all of these patients is to be able to maintain oral nutrition. So the traditional recommendation in people with diabetic gastroparesis would be small meals, low in fat, low in fiber, and a low particulate diet. Versus a low particulate diet. So the traditional recommendation, it limits a lot of food groups. Patients may have some difficulty sticking to it as well. I'm going to talk a little bit more about low particulate diet in the next component. Not something else that may also be helpful for these patients is to increase the liquid proportion of their diet, because liquid emptying is often preserved. So this is easy advice to give somebody: more liquids, less solids, whether that's boost or insure to substitute a meal, may help them just manage their symptoms. Whether or not they need enteral or parenteral nutrition is ultimately going to end up based on the severity of their symptoms and the ability to control with conservative management. And I'll talk a little bit more about these. So what is a low particulate diet? So low particulate diet is essentially blenderized or anything that's easily mashable, baby food type things. This doesn't make me very popular in my clinics, but there is good evidence to say that this is better than our traditional recommendation of low fat, low fiber meals. It doesn't limit fats, which is good for overall health. So it is a more varied approach. However, it's a change in texture. So patients may not be accepting of this, but if they are, this is what I would recommend. So increasing liquid components, as well as doing a blenderized diet, or when symptoms are even flaring or worse, to do a few days of a blenderized diet versus a few days of more liquids in the diet, as opposed to more traditional recommendations. Okay, so when we need enteral nutrition, so of course the goal was always to maintain oral nutrition if possible, but if we get to the point where oral nutrition is not adequate, we need to consider whether this patient is going to benefit from enteral nutrition versus parenteral nutrition. So someone with ongoing weight loss or decompensation related to their symptoms that is not able to continue despite oral dietary management. So enteral nutrition is favored over parenteral. This will obviously avoid the effects or potential complications of parenteral nutrition, not limited to line thrombosis, sepsis, multiple potential complications. The other benefit of enteral nutrition is maintaining integrity and the mucosal immunity in the GI tract. So it is much favorable if it is possible. If someone needs a short-term solution, an NG, or more likely an NJ, so a nasojejunal tube, can be used for less than a month if they're having just an acute flare that we're hoping will resolve. If not, most of these patients who need enteral nutrition will end up needing jejunal feeding. Gastric feeding is generally not recommended, though some people will tolerate it. And if you consider that liquids do empty fairly normally in gastroparesis, and if they're dripped in at a slow rate, they may be able to tolerate a slow rate of G feeds. And G feeding is much less complicated than J feeding. That being said, ultimately, most will require conversion to jejunal feeding, and rarely even gastric venting through a G port. So before anyone gets a PEG-J or jejunostomy, they should have a successful trial of nasojejunal feeding, so something that's reversible, easy to remove without making an incision or avoiding potential complications of a ostomy in for example, a diabetic patient who's at high risk of wound infection. It is quite possible that patients with gastroparesis may also have small intestinal dysmotility and may not tolerate jejunal feeds. So you want to confirm that they're actually going to be able to tolerate feeding into the jejunum before a GJ is placed. GJs can get complicated. The statistics I found are about 50% requiring reintervention at 6 months. I would anecdotally say it could be even higher than that. They are quite prone to difficulties. And one issue that comes, particularly if a patient is vomiting, would be migration of the J port, as well as dislodgement of the J port. And wound infection, as well as tube leaking, et cetera, always needs to be considered, especially if these patients have poor immunity or poor wound healing. So we'll talk about pharmacotherapy for gastroparesis. So prokinetics and antiemetics make up the large proportion of what we're using. So spelling error here. So metoclopramide or domperidone, I'm sure you're familiar with, are the two most commonly used upper GI prokinetics. Mostly work on D2 antagonism. The big difference between metoclopramide and domperidone is crossing of the blood-brain barrier. So domperidone does not cross the blood-brain barrier. So with metoclopramide, you get the potential extrapyramidal side effects, as well as tardive dyskinesia, which is overall thought to be really quite rare and unusual. But it is a consideration if you can use domperidone over metoclopramide for long-term use. The benefit for acute management of these patients, particularly hospitalized with metoclopramide, is that it's intravenous, whereas domperidone is only oral. So they're both moderately acting prokinetics. They both prolong QTc interval. And in terms of long-term management, there is some expert guidance on how to monitor these patients on these medications. However, no clear guidance on what to do, but they prolong in QT, especially if they're on multiple other medications. So this can be a use-limiting issue. They're both prone to hyperprolactinemia based on the D2 antagonism. Okay, so erythromycin you may be familiar with. So erythromycin is a motility agonist. So if you can remember, we talked about how the stomach moves in the fasting state by the migrating motor complexes, so those large sweeping movements. So erythromycin will augment those sweeping movements in the stomach. It is quite a strong prokinetic. The major issue with use of erythromycin is tachyphylaxis. So there's no long-lasting effect on gastric motility, so it's not for long-term use. Considering potential antibiotic stewardship, you can consider whether or not it is appropriate to use these in a patient that you don't have many other options who's hospitalized. You can use it intravenous, which is a benefit. And it does have a good prokinetic effect. So potentially useful for short-term management of a hospitalized gastroparesis needing IV medication, but not a good option for someone on outpatient on long-term management. So prucalopride. So prucalopride is a prokinetic. It's a pan-GI prokinetic, essentially. It is approved in Canada for chronic idiopathic constipation in women. You have to consider if you're using this for something like gastroparesis, which would be off-label, that a patient can get diarrhea given that it is indicated for constipation. But if they have idiopathic constipation, that could be something that's also useful in management of their constipation. The benefit of prucalopride is that it doesn't prolong QT interval. Overall, the evidence for gastroparesis is not strong. 2 small randomized controlled trials with a overall low number of patients. It has been found to improve cardinal symptoms in one study and improved gastric emptying time in both. In the smaller study, which is only 15 patients, it wasn't found to improve cardinal symptoms. So may be something that is potentially useful, particularly if your patient has coinciding or is a female with coinciding chronic idiopathic constipation. Okay, so we're familiar with ondansetron as essentially an antiemetic. It is commonly used in in gastroparesis patients who have prominent nausea symptoms. It's not been controlled, or there are no controlled studies in use in gastroparesis, but is often used as an adjunct for nausea. So other medications that have been looked at. So there's a very recent study on buspirone, which is a 5-HT1 agonist. Unfortunately, it was a negative study for cardinal gastroparesis symptoms. However, there was improvement in severe bloating, which is interesting, but not really any benefit in gastroparesis, unfortunately. Mirtazapine's been looked at in a small study with open label with 30 subjects, and it was found to improve cardinal symptoms, can have benefits of improving appetite as well. And I believe the dose used was 15 milligrams at night. So there's no formal guidance on long-term management of or monitoring QTC interval on patients who are on long-term prokinetics. What's generally expert best practice recommendations is an ECG prior to starting and then at least yearly, which is pretty similar to what I do, and your usual targets based on women or males or females. So I'll talk a little bit about interventional treatments for gastroparesis, something that is a little bit more exciting in terms of management and what's been tried and hasn't really been effective. Sometimes patients do ask about these things, they read them in the literature, they want to know if this is going to be an option. So pyloric Botox injections, if you remember the pathophysiology we talked about pyloric spasm or failure of the pylorus to relax, it can seem pretty promising to inject pyloric Botox into the pyloric sphincter to help this relax. And we know that in achalasia, this can give a few months of benefit. So this was looked at with injection into the pyloric sphincter. Interestingly, patients with both saline and Botox injections into the pyloric sphincter had improvement in their symptoms, but also their gastric emptying. So the saline injection patients actually improved in their gastric emptying, so a pretty strong placebo effect. For both, unfortunately, there is no sustained benefit of repeating Botox injections, so likely all related to placebo. So this is essentially rarely done or mostly abandoned. They've tried putting a stent in the pylorus to see if you could keep it open, allow food to pass more easily. Small study, which was positive, however, open label, and also unfortunately results in stent migration. So this was essentially abandoned as well as not an effective way to manage these patients. So something that is more exciting is the gastric oral endoscopic myotomy. So you might be familiar with POEM use, which is standard of care for achalasia. So POEM essentially in achalasia is the same as POEM in gastroparesis. The ultimate purpose is to remove muscle here in the pyloric channel, which in achalasia, it's basically doing the same thing in the lower esophageal sphincter, or the esophageal body. So you can see here on these images, this is the pylorus. Sorry, this is the pylorus here. Here's the needle knife, and they're cutting into the mucosa to make a channel and removing essentially muscle through the pyloric channel, placing clips to close the wound, with the ultimate goal here of allowing the pylorus to stay open and food to empty more quickly. So what is the evidence to do GPOEM? So there was a prospective trial in 2021, which had a moderate success rate of 56% to 12 months. The people who had the most success in the study were significant gastric retention, so greater than 20% retained contents at 4 hours. If you remember from previous, what's normal would be 10% or more than 10%, less than 10% remaining. So a significant delay. This would be a high symptom index or high symptom score, and early response also predicted a later response. In a systematic review meta-analysis more recently with 560 subjects, actually found a clinical success rate of 75% at 36 months and a pretty low rate of overall complications. So this is a potentially exciting thing in the role of gastroparesis. So what is the role right now, or who is getting POEM? So POEM is suggested for refractory gastroparesis. So what we mean by refractory is they've really tried all medications without response. Essentially nothing has worked. They may or may not have failed other advanced therapies, and you could see from my previous slides that these generally are not recommended regardless. So they're not really a prerequisite that they have failed these prior to considering someone for POEM. They have moderate to severe symptoms with significant effects on their quality of life and functioning, and potentially nutritional effects as well. And they have a confirmed diagnosis of accurately diagnosed gastroparesis. If they're on opiates, or their study was done on opiates, they should be weaned off opiates and have the gastric emptying study repeated to determine that they have true gastroparesis and not an effect of opiates on upper GI motility. So the issue comes with POEM is who are we sending or who's going to be a good candidate for POEM. So predictors of success we know from previous studies would be a high rate of gastric contents remaining at the 4-hour mark, severe symptoms, and a high symptom score. There is a technique called endoflip, and they've considered if patients who respond to pyloric Botox could be good candidates, but ultimately it's difficult to find patients who truly respond to pyloric Botox. But there's another technology called endoflip. So endoflip is basically, I'll only talk about this briefly, but it's a technology where you can place a little probe with a balloon through the pyloric sphincter. And this is better described in achalasia. And it basically tells you the distensibility of the pylorus, so whether or not this pylorus is stretchy, essentially. So it's proposed that a good candidate probably has a low distensibility. So this is what it would look like on the imaging. So the pylorus is not very stretchy, though it's been proposed that maybe these patients would be the better candidates for POEM, but it still requires more studies on whether this could be used as predictive value. So right now it's not required that a patient has had an endoflip assessment prior to being referred for POEM, but something that could be considered. Okay, I just wanted to include a slide on gastric pacemakers because it is a question I think patients often ask. So they're not available in Canada anymore, or right now. They are not FDA approved in the US. They are approved as a humanitarian use device, and this is essentially due to lack of evidence to use them. They are relatively contraindicated in opioid users, and that's because of very poor response, essentially, and then the consideration of immunosuppression due to infection of the leads. In terms of who is more likely to respond would be diabetic patients. Overall, there is no improvement in gastric emptying with Intera with the gastric pacemaker, but they can improve mildly some symptoms in some patients of refractory nausea vomiting. And this is thought to be some sensory modulation of the interstitial cells of the collar, the pacemaker cells, and sensory afferents. The issues you can consider with this, in addition to the contraindications, is also lack of accessibility, expense, and patient having to travel, and then to consider that the batteries will die and they would also have to have a battery change in the US. So they're not very accessible and not necessarily recommended. So I just wanted to sum up with a slide on approaching refractory patients. So if you have a refractory gastroparesis patient, so you've applied nutritional management, changes in diet, lifestyle, they're still having nausea, vomiting, you've used prokinetics, you've added antiemetics, and they're still not getting better, it helps to consider, am I truly dealing with gastroparesis or am I dealing with something else? So are they predominantly complaining of abdominal pain or discomfort? And should this patient be considered to have functional dyspepsia or be treated for some type of sensory abnormality rather than true gastroparesis? Are they really complaining of dyspepsia or abdominal pain? If not, and they're complaining of persistent nausea and vomiting, consider, could there be something else going on? Is this patient really gastroparesis? Is it really postprandial fullness, postprandial food intolerance, and postprandial nausea, vomiting, early satiety? Other things to consider that are common: cannabinoid hyperemesis is quite common. Cyclic vomiting syndrome, if you seem to have episodes where their symptoms are very severe and then they remit, and they're very severe and remit, but they generally don't have a lot of food intolerance or early satiety between episodes of symptoms. Whether they have something else like narcotic bowel syndrome, constipation leading to their symptoms, or whether their symptoms started after onset of opiate therapy. Do they have rumination syndrome? So something that might suggest this is not a component of nausea, but just recurrent regurgitation. And that can help you guide further management. So in terms of your refractory patients, always go back to your first thing, which is a medication review, nutritional management, oral if possible, enteral if needed. Review, have they tried their medications? Have they tried them appropriately? Antiemetic medications. Is there any role for prokinetics if they haven't tried them on an adequate basis. Generally wouldn't recommend combining prokinetics, and no evidence to do that in a likely overlapping mechanism. Is their constipation optimized? And then if all that is true, it ultimately goes back to nutrition, and then consideration of whether this might be a gastroparesis patient who would be a good candidate for AG poem that I talked about. And ultimately might be somewhat difficult to find patients in this cohort that are truly good candidates, that are not on medications like opiates, that have their glycemia controlled and those sorts of things. Okay. So just to sum up the take-home points, so gastroparesis is a neuromuscular gastric disorder characterized by abnormalities in accommodation, enteral peristalsis, pylorospasm, and increased pyloric contractility. So multiple things going on, not just necessarily disorder of true emptying. Diagnosis made by cardinal symptoms: nausea, vomiting, early satiety, absence of mechanical obstruction, an abnormal 4-hour nuclear medicine gastric emptying study that has been done off offending medications that can delay gastric emptying and in the absence of hyperglycemia. So it was done in a normal physiologic state. Overall management includes removal of offending medications, optimization of glycemia, good nutrition before and after, medical therapy, prokinetics, antiemetics, and then consideration of advanced therapies, particularly G-POM in very well-selected cases. Okay, all right, so move on to some questions.
Dr. Woodman, thank you so much for this comprehensive presentation covering our pathophysiology as well as advances in the evidence in the treatment of gastroparesis. I believe Dr. Gernstein has a question in person. I'm going to allow him to get in. I'm sure he sees many of these patients. So,
thank you. And Kathryn, that was a really very nice, thorough, and balanced presentation. So I think that's really great to see, and it's very relevant to everybody who does medical care across specialties. I just want to make a comment and a question. The first comment is regarding GLP-1 receptor agonists. Until now, these have mainly been used by endocrinologists, but that's changing, and it's going to change a lot. So all of you are probably, everybody's going to be seeing people, and they'll be starting GLP-1 receptor agonists because of their cardioprotective effect in obesity, separate from diabetes, in addition to all the diabetes things. Important thing to know is every single patient who is started on a GLP-1 receptor agonist will experience some early satiety. They will, and they should always be told to reduce the speed of eating because gastric emptying is slowed with the drug. And they do have some, often will complain of a little bit of nausea, but all of the large randomized trials clearly show that within the first 1 to 2 months of therapy, the vast majority of people, their GI symptoms, both their lower and their upper GI symptoms, go away completely. Maybe because the drug has made them modify their dietary patterns. But please, if you start the patient on a drug and they're complaining of a little bit of nausea, it doesn't mean that they have gastroparesis. This is a known side effect, and it passes with time. And that's really important. The second comment is that there is a disturbing tendency amongst even endocrine fellows, but residents often and sometimes colleagues, that any patient with diabetes who vomits has gastroparesis, which is clearly not true. And I think it's really important to say that to a large extent, this is a diagnosis of exclusion. As you said, even type 1 diabetes, long-term 5%, and type 2, 1%. So do not just dismiss it and say this is gastroparesis and walk away. There are other causes, as you very nicely elucidated. And my question is, both general internists as well as endocrinologists see patients who, you hinted at the end, who have recurrent vomiting, and often that's dismissed as gastroparesis. But my impression and my reading is that these are really two separate diseases to a large extent, and people who have lots of vomiting. First of all, vomiting itself can cause delayed gastric emptying, but that there's two different things going on. So I wonder, could you sort of maybe try to paint a picture? How do you distinguish gastroparesis with vomiting versus a primary vomiting problem, which is not a thing, because that vexes a lot of us. And there's always a few frequent flyers that keep getting readmitted if they have diabetes or ketoacidosis because they're vomiting. But which is first, the vomiting or the metabolic? And without diabetes, there's some patients who can't be admitted with the recurrent vomiting. So if you a little bit of expansion, that'd be helpful. Thank you.
Absolutely. Thank you. And thank you for your comments on GLP-1 agonists. I completely agree. And as well, I agree with the fact that they do improve over time. And I've found that I actually will refer to patients who have started on a GLP-1 inhibitor with new upper GI symptoms. And by the time I actually see them, they've completely resolved and they've done well on the medications. They're able to continue at longer term. So absolutely a physiological effect from the medication. In terms of differentiating the diagnosis of gastroparesis versus a different vomiting syndrome, as you know, that can be very difficult. One thing to look at is, do they have the cardinal symptoms of gastroparesis? So generally, because gastroparesis empties liquids pretty normally, a lot of these people will tolerate liquids without much issue. The other thing is, are there symptoms postprandial? So is this a problem of the stomach not emptying, or not accommodating appropriately? So if they're taking in food and they're developing symptoms postprandial with poor tolerance of food, early satiety, so that might be more suggestive of a neuromuscular disorder or gastroparesis on the stomach. And then the other question, if they've had a gastric emptying study, how was the gastric emptying study done? So was this done in the hospital on a patient who was hyperglycemic at the time, who was medically sick at the time, that of course can also delay gastric emptying, or was this done when they're a well outpatient? So the appropriate time to do a gastric emptying study is when they're home and when they're on their baseline symptoms, is not when they're kind of having an acute exacerbation. And then, of course, if they are vomiting in a cyclic pattern, that they're presenting to the hospital during cyclic periods only, is this actually cyclic vomiting syndrome or something else like functional vomiting syndrome versus gastroparesis? And that can sometimes, of course, because of overlap, be difficult to tease out, but those historical factors might help you answer that question better. And of course, even someone with an abnormal gastric emptying can still have functional dyspepsia or functional vomiting, which makes the whole thing pretty confusing.
Oh, the other point, that's great. The other point is that if we don't ask the question, a lot of older people are taking a lot of cannabinoids, especially if they have pain. And so that's another issue that you mentioned as well. So, yeah.
Absolutely. Yeah. Cannabis hyperemesis, very common in these patients too.
Thanks, Herzl. I think it's a great comment. And thank you, Kathryn, for responding to that. I actually want to have a follow-up on that question because we don't want to label patients inappropriately as gastroparesis, and I've taken care of some of those patients I was referred to in hospital, and everyone says they're gastroparesis. How important it is to have a proper motility studies on patients before you label the diagnosis. I mean, I understand the cardinal symptoms, but then how important is those patients get referred to your motility clinic and get properly diagnosed?
Yeah, that's a good question. And I mean, you can have a good suspicion on someone who has a high positive or a high predictive value based on, a long history of diabetes, neuropathy, et cetera. However, if I have a patient who I see with suspected gastroparesis, but they're on opiates, or they're on something else that might delay gastric emptying, I'm not going to do a gastric emptying study right now because it isn't going to be helpful. It's not going to tell me whether this patient has a neuromuscular disorder of their stomach or if they have effects from medication. I can't differentiate that based on a gastric emptying study in that patient. So I'll either try to taper them or do the study off medications if possible. But ultimately, I think what helps you differentiate is predicting whether or not this patient is going to respond to prokinetics. But a lot of the things I would start even before I did a gastric emptying study. So dietary modifications, if you have someone complaining of early satiety or postprandial nausea, and those things you can start right away. I would say it is helpful to some degree to have it, especially if you get someone in the refractory situation and you're thinking about whether or not is this going to be a good candidate for something like POEM, because then you want to have a good gastric emptying study that's done appropriately.
Fantastic. So question from Dr. Satya is, does azithromycin has the same pharmacokinetic pharmacodynamics effects on motility or motilin and similar to erythromycin and being longer acting? Has that been looked at?
Sorry, erythromycin compared to?
Azithromycin.
Yeah, I think it has, and I think the actual whole macrolide class augment motilin. So we'll have similar prokinetic effects. I'm not exactly certain why we would use erythromycin over the others, but one, of course, being an intravenous option for acute use. It's not something that I would use very often. It's not something I've ever used on an outpatient, but is something I have occasionally used on an inpatient.
Erythromycin was very popular before the other safer prokinetics that has come up. It's interesting. I have not seen azithromycin used, but I think theoretically it could work. I don't know if there were any studies on it.
Yeah. If you look up the data, it does accelerate gastric emptying as well.
Amazing. I have Dr. Dorsami question in person. Panji, go ahead.
Thank you, Dr. Woodman. That was an excellent talk. I wonder if you can hear me. Can you hear me?
Yes.
Yeah, thank you. So one of the pathophysiologic mechanisms that you've discussed relating to the pylorus being overconstricted, as it were, is the nitric oxide synthase, which I think you mentioned there may even be a deficiency. So I think that's an important sort of aspect of pathophysiology, because nitric oxide, as we all know, is probably one of the final common pathways in a number of vascular sort of conditions and smooth muscle conditions, because it is a vasodilator, and it's a potent vasodilator by its effect on on the cyclic GMP system. Have you ever considered that perhaps drugs or medication that may increase nitric oxide levels and result in an increase in cyclic GMP may have an effect on the pylorus in this situation?
That's really interesting, actually. And I don't know that we're even really to the point of we can identify a gastroparesis patient and say that your symptoms are entirely due to pylorospasm, which is kind of different from achalasia, where we know that we can do an esophageal manometry and we know that their symptoms are related to loss of nitronergic neurons and failure of the LES to relax. Whereas achalasia, with gastroparesis, we're not even to the point where we can say that this patient is entirely pathophysiology is related to failure of the pylorus, but can be essentially suspected, particularly if you have someone, you've done endoflip and you see that the pylorus is not very distensible. But I don't think it's been looked at in terms of augmenting increased nitric oxide at the pyloric sphincter, but it's a very interesting comment, and I'll have a look into that and see what I can find.
Just to take that further, there are a number of drugs. So one of them is the phosphodiesterase 5 inhibitors, for example, sildenafil. They increase cyclic GMP levels, but in fact, they require nitric oxide to be present. But if you look at other drugs, there's a drug called riociguat that is a guanylate cyclase stimulator that doesn't require nitric oxide and directly stimulates the guanylate cyclase system, increasing cyclic GMP and causing vasodilation or smooth muscle relaxation.
Very interesting. Yeah, I'll have a look into it and see what I can find in terms of data, but I'm not aware of whether that's been looked at.
Thank you.
Thank you, Panji. Just a question from Dr. Derek Hunt. Do you find that your patients with diabetic gastroparesis often have symptoms that ebb and flow over time? And we see this in clinical practice, especially those end up being admitted with gastroparesis, so
Yeah.
what are your thoughts on that too?
Yeah, I do. And you know what I'll say that I think maybe is probably not realized is that the large majority of gastroparesis patients in my practice are super well. They're really easy to manage. They only require mild dietary changes or a simple prokinetic. But generally, I find most of my diabetic patients ebb and flow to some degree, but I don't tend to see a lot of big swings in terms of acute exacerbations requiring hospitalization in my true diabetic gastroparesis patients that I follow, once a year, check in how they're doing, check their ECG, represcribe their prokinetics. Most of them might say they had a period of stress or a period of medical illness where their symptoms increased for a few months, or they have somewhat improvement with their glycemia improving, but overall, I'd say in time, they're fairly stable.
That's very interesting, because to Dr. Gerstein's point, about those patients that end up getting admitted with gastroparesis, most likely have something different than, where think about their hyperglycemia, think about their medication, where we just keep pushing. And the other thing I look at is, like with our general GI practices, I mean, we don't have access to your expertise inpatient, and whether we should have access to your expertise as an inpatient, or as just general gastroenterologist would be the one who's going to help us decide whether we need your help at that point or not. Something that we should think about at the level of the hospital delivery of care.
Absolutely.
There are a few questions here. There's a question about since the etiology is being heterogeneous, is there a more cause-specific treatment, like if the etiology is autoimmune?
Sorry, can you say again?
So it's in the Q&A, it says etiology is, so is there more cause-specific treatment if the etiology is autoimmune?
Is autoimmune. So in terms of autoimmune causes of gastroparesis, so it's not always 100% certain to say that, say, for example, my patient with scleroderma has gastroparesis related to scleroderma. You could say it is probable based on what we know about their history. However, treating the underlying condition is really the only way to manage the gastroparesis in terms of standards. So there isn't any specific treatment that we use in patients who have a specific underlying etiology. The only thing I would say for the post-infectious cases, because they do spontaneously resolve, like the case I presented, low intervention would be appropriate. So doing what you need to do, but only doing that and reassuring them that they do have a good prognosis.
Okay, I have Dr. Tolman.
Yeah, thank you. Just a quick question. It always bothers me, this concept of doing an ECG to look at the QT interval and deciding that it's safe to use a certain drug, because the QT interval is prone to change from different things, including electrolytes and the addition of other medications. So I'm just, this isn't maybe necessarily related to your talk specifically, but can you comment a little bit more about what you know about the use of one static ECG at one point in time in terms of the effect on the QT interval?
Absolutely. I really appreciate that comment, because this is a bit of a difficult area, because we always have patients who have had a one-time prolonged QTC and all the rest of their ECGs have been normal, and then they end up being not a candidate for all these very good prokinetic medications. And we don't really have the data to say whether or not this matters, or whether or not looking once a year is going to be adequate. I'd like to know what the whole electrophysiology community thinks about this in terms of what we're doing with monitoring QTC in these patients, because really it's just an opinion-based thing that we're doing. I think the overall risk of having cardiac arrhythmias, particularly in erythromycin, but in prokinetics in general, is pretty low. So we might even be a little bit overkill in doing these.
Sounds like we could have a grand round with a debate over what do you do with the QT prolongation with all the medications we use in medicine. So very good point, Marianne. Appreciate it. Can take one last question, and this is from Dr. Priptani, and it reads, if no clinical upper GI obstruction symptoms and you suspect gastroparesis, do they need, I'm assuming it's like like EGD or GI studies?
So would this be, for example, just in maybe a diabetic patient, I'm presuming, who we think might be at risk? So I would say, because if there's no weight loss or no other concerning symptoms, because it's not really going to harm the patient to have delayed gastric emptying if they're nutritionally adequate, there likely isn't any benefit of doing any empiric investigations.
Good point. I think we're at time. This has been a great discussion. Dr. Woodman, thank you very much again for a wonderful presentation. Very informative, as I expected. I've learned a lot today, things that I'm going to take into my practice. Maybe today I'm going to be admitting a patient with gastroparesis. Not really. And we'll improve the practice then. Greatly appreciated. And I thank you again. And thank you everyone for attending this morning, and have a wonderful rest of your day. We'll see you next week.
Thank you. Thank you for having me this morning.